And if you said to a businessman, I can take your business and you lose a lot of your customers before you get to what you're trying to deliver, but for 3 simple rewards, you can lift your 10% to 45%, they'd bite your hand off for that, you know.
Welcome to Dopamine Dialogues, the show where we meet experts working with contingency management, translating the science into what actually succeeds in clinics, communities, and day-to-day operations with patients, clients, and beneficiaries. So whether you're a provider, payer, policymaker, or just CM curious, you're in the right place. I'm your host, Larry Klemchek. I'm very excited to introduce our next guest, Professor Sir John Strang, who's got over 40 years of experience in addiction management. Welcome, John.
Well, it's good to be in conversation with you.
John, to start off with, could you just tell us a little bit about yourself and how did you come to have a passion about substance abuse and becoming an industry expert?
I guess I sort of had my adolescence in the 60s, and so my generation was hit by drug problems, and it seemed very relevant to the areas that concerned me. I don't come from a medical family or anything, so I was moving into studying medicine very much with a sort of social theme to it, about were there aspects in which without being too grand about it, sort of the world might be made a better place, by interventions. And psychiatry attracted me in that regard because of the connected nature to society and to people who had disadvantage also. And working in psychiatry, one of the areas that I had the opportunity to work in was the addictions field. I'd already had an interest in it. I'd done voluntary work and such from my teens onwards. Once I started working in the field, I actually remember the experience, realizing that it felt like putting on an overcoat and thinking, wow, this feels like it was made for me. It sort of fits, and it just instinctively felt comfortable. And within that field, I was initially exclusively a clinician, doing my sort of medical training and working in the addictions field. But more and more, I found myself wanting to explore questions and became involved in research projects. And sort of mid-career, decided to reconstruct myself in an academic domain and did a doctorate, and opportunities arose. I very much liked the ability to explore new territories and to try to integrate clinical practice with science and policy, and they don't always get considered in a connected way.
That's great, John, because many of the people that I do speak to, they've ended up here because of the people that they were around and what they were seeing, and then how they could, they had a connection there of how can I help these people, and your story sounds similar to that. I also love what you just said there at the end about bringing together clinical practice, science, and policy, and when you bring all 3 of those together, then that's when things really start changing around you. So thank you for those initial comments.
I think you're right, and it's often quite difficult for people in each of those domains to achieve that, and it almost involves a sort of forced development of the relationship. It's as if people are speaking variants of the same language, but not quite the same language. Yeah, for people listening in, I think it's worth the effort. You get a richer understanding if you can see it. It's like you get a 3D perspective instead of a 2D perspective.
John, one of the things I've read about is you're using contingency management incentives to improve completion of hepatitis B vaccination in people undergoing treatment for heroin dependence. Can you share with us a little bit more about some of your experiences in this, and what are some of the outcomes, and what are some of your thoughts?
My own view is that it's useful to think about it as if it was another medication. Now, clearly, I'm fully aware it's not a medication, but if we discovered there was a co-medication that you would take with your blood pressure medication or your diabetes medication that made it 30% more effective, you'd go, wow, sort of tell me about it. And is it really expensive and difficult to administer, or does it have side effects? And if you think of contingency management in that space, it becomes what a businessman would regard as a no-brainer. Now, the personal way in which I became focused on an interest in contingency management is I'd been invited by our National Institute of Clinical and Health Excellence, which is often called NICE. I'd been invited by NICE to chair a group looking at non-pharmacological aspects of addictions treatment, and lots of things came out as exerting a beneficial effect, but they were all of pretty small effect size. And the one standout intervention was contingency management, which was it was like an order of magnitude greater effect size compared with the other interventions. And on the back of that work and the report that came out from that, we secured funding for a program of research looking at contingency management in the addictions field. And we decided for the program we wanted to study two different types of effect. One was an effect which was where the benefit, you couldn't lose it. So there might be some tasks you needed to achieve. And we chose hepatitis B vaccination. So here was a group at high risk of hepatitis B, which causes chronic liver disease with the risk of liver cancer. So, this might be regarded as trivial at the time, but the long-term implications were pretty huge. And a vaccine was by then regularly available, and there was very little attention to it from either clinicians or from the patients or the drug user population. And when it was administered, it involved 3 jabs. When it was initiated, it would often not get round to the second or third injection and it would fizzle out.
It's a big dropout.
Yeah. So we decided to test, okay, could you incentivize the completion of Hep B vaccination course? And it was transformative. We did a randomized trial, a cluster randomized trial, looking at the normal encouragements that would occur versus a simple reinforcement schedule for it. And the 10% completion rate became something like 45% completion rate. People should go away and read the paper if they want to check the exact figures, but I mean, those were broadly correct. So you think, wow, for a short-term gain, you can definitely bring about major transformative change. And if you said to a businessman, I can take your business and you lose a lot of your customers before you get to what you're trying to deliver, but for 3 simple rewards, you can lift your 10% to 45%, they'd bite your hand off for that. So having done that, we then moved on to looking at could one bring about longer term change, so either more regular attendance at clinics, quitting of the problem drug use, which we were working with opiate users, so quitting their heroin use with urines that were negative. And there we looked onto a longer challenge. And ideally, we'd have looked at an even longer bit of work, which would look at having reinforced that behavior change for 2 or 3 months. Was there then momentum to that change that would continue without you needing the reward structure? And that's actually an area which I think has still not been properly explored, because behavior change does acquire a momentum, but we really need to know more about how long do you need to reward something for it to become ingrained, and are there ways of preserving that momentum of that behavior change?
My next question, John, is, what do you think that the misconceptions are about contingency management? Because as you said, it works. And so, but people aren't adopting it at the scale that we believe people could be. So what could those misconceptions be that you think are still lingering?
I think part of it is people struggling with the idea that something like either incentives or cash payments or whatever it was, that could be a legitimate therapeutic strategy. it's sort of seen as I'm not sure if the language translates, so but mollycoddling people or just charity or something like that. And I think also for clinicians, they need to understand the behavioral principles they're following. They need to realize they don't provide that reward or incentive just because they're feeling sorry for somebody and that they want to help them have enough funds for lunch. That they can be compassionate in other ways, but if they're following a behavioral strategy, they have to adhere to that pretty strictly, or they weaken the effect of the medicine. Using my analogy from earlier, if it was a medicine, it's like you're not taking the medicine properly. And both the clinician and the recipient need to understand what the objective is and to have agreed to that.
Oh, very interesting. And we've talked about this with other guests, and it's in that implementation side of things to adhere to the fidelity. Okay. But it's also, for the clinicians to get the proper training, right? It's more than just the reward. It's also that human interaction. It's how the reward is given out. And that's that positive reinforcement or that conversation. So it really is, it's not just a reward or an incentive. It is a true treatment process. And I think that is, a key element for everybody to take into consideration when they're implementing contingency management or expanding contingency management.
Yeah, Larry, I think you're absolutely right. And if one's looking at the underlying principles of it, you also want your stimulus response relationship to be, you want the connection to be as strong as possible. And that's the sort of area in which your clinician or your treatment service has got to make sure that it gets stimulus and response as close to each other as they can possibly be. And you can imagine the worst case scenario where you've demonstrated the behavior that should have the reward, but somehow you've got to wait in a queue for a couple of hours to get the reward. It's just not gonna work. It's like
Impact lost, isn't it?
For
And
all of us.
something else could be triggering then the association with the reward, right? So having that human conversation and then whatever the behavior is that you're rewarding, and hopefully in many cases now it's actually abstinence. So it's not just attending something. So please go ahead.
Yeah, and I think one's also got to work with the individual about what is an agreed behavior change that they and you are working towards. I mean, I think one of the other mistakes, and coming back to the parenthood example, there's not much point you working out a behavioral schedule with your teenage son or daughter if they aren't signed up to it as well. And that preliminary clarification about what it is you're setting up is crucial. I think the other point to bear in mind is that we're now in an age where we have the technologies that make this much more achievable. It doesn't need to be a piece of paper that is written out, which is then taken to a clerk's office to be double stamped and so on. Now everybody is walking around with the digital technology in their pocket for an instant relationship. And that sort of takes one into a realm where the reward doesn't even need to be the reward in the literal financial sense doesn't even need to be delivered. If I feel my phone buzz when I've done a banking transaction, I know that's the confirmation that it's occurred. Yeah, I could get my phone out and open it up and look at it. But if the time relationship is right, I can carry on with whatever task I'm doing, knowing that I felt that reassuring buzz. Developing those sorts of ways of taking CM into the digital world make it much more realistic to deliver to a wider population. And that's very much a space that you guys have been working in.
Excellent. Well, yeah, thank you for your thoughts on that. John, I know that you're doing some work in and around naloxone carriage. I mean, naloxone saved millions of lives. It's an amazing, amazing treatment. But how do you see CM adding value there with naloxone carriage?
From a personal point of view, it's a very sweet project because it brings together two areas of interest from my point of view. So as per the discussion just a bit earlier, I've become very interested in contingency management and remain puzzled that it isn't more widely applied. I've also had a particular interest in can one develop new strategies to reduce the burden of opioid overdose deaths that occur. Hopefully the naloxone that is given out is never used, but you want it to be there just in case that crisis occurs. And one of the big problems that has emerged, naloxone availability in many countries of the world from a regulatory point of view is actually pretty good. The barriers to obtaining it are becoming less and less. But one of the areas where it seems to me it really does fall down is in the carriage rates of naloxone. So for naloxone to be effective, you don't know whether you're going to happen to be there at an overdose event. So you need to have your naloxone with you at all time. It needs to be something which is like your phone, like your wallet, like your watch. It's just something that is there with you at all time. And when we do surveys of people who've been given naloxone supplies, who are supportive of naloxone being carried, when we then ask the question, and do you have it on you now? We discover it's somewhere around 10 to 15%, maybe 20% at best, of people who actually have it on them. And in a slightly flippant way, it's a little bit like condoms. They're extraordinarily effective about what they're meant to do, but they just don't work very well if they're 3 miles away in a bathroom cabinet. They need to be on you at the time of need or at the time of crisis. And so with that problem, just suddenly these two areas came together and you just go, hold on, we got a problem that people aren't carrying their naloxone. And then earlier that same day, I'm in a meeting about how we can change human behavior by having an incentive scheme. How could one devise a sort of phone-based CM strategy that might mean that at any time I might be asked, have I got my naloxone on me? And there's a reward structure around, yeah, I've got it on me. Here it is, ka-ching. I sort of feel the buzz in my pocket. Now, whether it'll work that way, I don't know, but we're piloting that as a strategy. Colleagues in the US are doing likewise, and we'll be looking at how does that compare with just active encouragement. I'm pretty certain we'll be able to bring about a major change in the behavior, both of drug users who should carry it with them, also their friendship network, also their families. But that's for future.
Well, John, I love the way your mind works, and you're always trying to save lives, and you're taking a straightforward approach on these things, which is fabulous. John, I've read that you've done some work with the World Health Organization. I personally don't know about that. Did you want to share anything that you've done with WHO?
When we very first started doing this, we were well, first of all, it was an idea, and then we took the idea to various user population groups, both in treatment and not in treatment, to check did they think it was crazy or would they be willing to do so. And we did similarly with family groups. And originally it was putting glass ampules in a little plastic box that people could take away, and then it became pre-filled syringes, then a nasal spray and so on. But what became clear maybe a decade into some of that work, working jointly with people from the advocacy user community was crucial to taking it forward. So you needed the statutory system of, in the UK, the NHS, and the broader treatment sector, as well as the user perspective in there. But what then became clear is that there was a level at which laws needed to be changed or national guidance would need to be changed. The World Health Organization, one of its functions is to put together guidelines documents, which there's no mandatory nature to it, but there's an expectation that countries around the world will look at that guidance and then do a check against how are we performing against that. And there was an opportunity in discussions with WHO to say there needed to be guidelines about overdose management and what should governments do to enable both the training for family members, for users, or for any workforce, like people working with homeless, that what training should there be provided, and what material resource like naloxone kits should be made available so that could be done. And 2014, WHO convened an expert group to put together guidelines for what countries should do, the checks they should apply. And United Nations organization called UNODC worked with WHO on developing those guidelines jointly. And they've had quite a major impact on prompting countries around the world to look at their practice in this area or their lack of practice in it and introduce changes that enabled it.
Fantastic, fantastic. Interesting. Again, that kind of ties back to something you were saying earlier, John, about training, fidelity, ensuring that really people know what the best practices are because they are evidence-based, and then following through with them. So interesting that this is a common theme on a couple of the answers.
Yeah, I mean, it is, because from the science point of view, you'd go, well, why are you wasting time on those sorts of committees? Hasn't the science already been done? And you go, yeah, but this is how you make sure that the science that's been done, it achieves the impact that you hoped it would achieve. And in fact, some of it at a personal level do then discover you're in interesting areas which where you wouldn't ever otherwise have been there. So from the WHO guidelines that I talked about, they then set up a variety of initiatives in countries around the world. So I was involved with helping set up some work in Central Asia countries, Kazakhstan and Tajikistan and Kyrgyzstan, and it takes you outside your comfort zone. You suddenly think, I don't know anything about the prison system in Kazakhstan, and suddenly I'm being asked for advice about how should they alter the preparation they do for people coming out of prison. And those are part of what, as either as clinicians or as scientists, when opportunities like that arise, I think there's real benefit in saying, okay, I need to be humble about the fact that my expertise is not necessarily applicable to the setting in which I'm going, but I do bring a certain expertise. And if that can be blended with local understanding of the system, maybe some blend of that can actually bring about progress.
John, where do you see contingency management heading in the future?
I don't think there's any area in which one shouldn't be looking at how to use those behavioral principles, both to encourage healthy behavior and also to help people move away from harmful behaviors. I mean, I do find it sad how much struggle there is in society about embracing it and harnessing it more fully, perhaps because it is so embedded within so much of our lives and we don't call it contingency management. And, coming back to things like the star chart for one's children at school, if you go, why wouldn't I want to extend that to have more influence? Now, I think it does raise some really sort of major issues, like, well, who determines what the objective is that you're seeking to achieve? How do you work in partnership with somebody about working that? Fidelity, absolutely. If I'll stick in the clinical realm for a moment, if the clinician or the patient both understand what it is they're trying to achieve. But I mean, I'd view it as having, I've actually just come out of a meeting which our government have been looking at issues around helping people with addictions problems who are in prisons at the moment. And you go, wow, what an exquisite opportunity to apply behavioral principles. Now, I've no idea whether that will occur in that setting, but you could take it many places outside the healthcare setting and apply it in a similar way. Education system, criminal justice system, life in general.
So I guess in summary, John, what I'm hearing from you is contingency management can really be moved into almost any area, and that's really encouraging, because if we can help people in many more areas of improvement or trouble, then that's fabulous.
Yeah.
I think again, you did say there, though, is make sure that you are identifying the exact behavior that you want to incentivize, that you want to treat. And then number two, ensure that the proper training is there for that human interaction. And finally, I think the other point that has been very consistent in this conversation is the adherence to fidelity.
I think you're absolutely right. The issue of fidelity is probably one of the areas where you could so easily see it going wrong. People being compassionate could inadvertently undermine it. If the teacher at primary school just gives somebody a star because they feel sorry for them, you'll undermine the actual benefit that it delivers. One point I would add that I think was, to me, an interesting surprise when we drilled down into the literature early on about contingency management, is that I think I had come to the field thinking that this would be most applicable to people who were poor, who needed the funding or something like that. And then realizing that these same reward structures, you might be a millionaire, but still, you're still going to be both hungry for the achievement and reinforced by achieving the achievement. So I know the literature shows that larger rewards are more powerful. I personally think that I'd view the conclusion from that work as the other way round, that yeah, larger rewards are rather obviously more powerful, but they're not much more powerful. Quite frankly, having the reward is what's powerful. That comes up as quite an important issue in conversations with funders who worry that this is going to run away with itself. I mean, you can bring them back to reality when you point out the costs of the alternative of not achieving any benefit are massively more expensive than the costs of delivering the
Yeah,
intervention.
1,000-fold.
Yeah, exactly.
Easily. The cost of one emergency room visit.
But you do have to bring them back to that. Just one other point on that. What is quite often a difficulty with that when you're dealing with big systems is that you might be bringing about a benefit in somebody else's department. So the costs you incur in a healthcare setting reduce the criminal justice costs. So from society's point of view, it really is blindingly obvious that you should implement the program, but the person whose responsibility is the health budget is reluctant to spend that dollar to save $5 in somebody else's budget.
Good point indeed. Good point indeed. No, you're spot on there, and I love your comment. And you're the first person I've been talking to that specifically highlighted this. Is it doesn't matter if you're what your current wealth is or whatever that you want to call it, your assets, but because the reality is it's a human nature issue. We all like being rewarded, and and it is not just the incentive, it's actually the treatment. It's that communication with the clinician about the positive behavior, and you bring all that together, and that works just as well for all sections of society. And John, today has been absolutely fabulous. Every time I talk to you, I learn many things, not just one or two. And I love your approach on saving lives. I love your curiosity, and I love your determination to keep solving new problems, or keep moving all of this forward. Is there any other things you'd like to add here at the end, John?
No, I don't think so. It is interesting being able to work with organizations like yourselves where you've got a grasp of what one can do from a technology point of view, whereas I'm needing to imagine what I could do with my iPhone, and you're actually familiar with actually how to do it. And so I think bringing those different areas of different skill sets together really is exciting. So, no, nice to work with you.
Thank you very much, John. And thank you to all of our listeners. Tune in next time to Dopamine Dialogues to learn more about contingency management. See you.